Hello, we are excited to have you join us for our inaugural hypertension education series, aka hashtag HypeEd series, or even Hyped series webinar. This series will focus on the presentation of hypertension physician papers. Today, we will hear about ambulatory blood pressure monitoring in children and adolescents, 2022 update, a scientific statement from the American Heart Association. We would like to thank Trudy Meyer, managing editor of the journal Hypertension, for championing this initiative, and also Lily No of the AHA for disseminating additional publicity for this event through the AHA Hypertension Skill Committee. We hope this will be the first of several collaborative education efforts. Dr. Matt Luther of Vanderbilt and I, Stephen Crowley from Duke, will moderate this session, which will be constituted by a 45-minute presentation followed by 15 minutes of question and answer. So please place questions into the Q&A. I believe we have more than 300 listeners enrolled, so I can't promise we will get to all of your questions. For this inaugural session, we are fortunate enough to have two distinguished speakers who are authors of the paper presenting the manuscript. Dr. Joseph Flynn is the Robert O. Hickman Endowed Chair in Pediatric Nephrology at the University of Washington in Seattle. Joining Dr. Flynn is Dr. Tammy Brady, Associate Professor of Pediatrics and Vice Chair of Clinical Research for the Department of Pediatrics at the Johns Hopkins University School of Medicine. To provide additional context during the Q&A, we have two more key authors of the paper on the call to act as panelist discussants. Dr. Elaine Urbina is Professor of Pediatrics and Director of Preventive Cardiology at Cincinnati Children's Hospital Medical Center. And Dr. Joshua Samuels is a tenured Professor of Pediatrics and Medicine in Pediatric Nephrology and Hypertension at the McGovern Medical School at UT Health and at Children's Memorial Hermann Hospital in Houston. We would very much like to thank our speakers and panelists for their time and participation. Now I will hand the electronic podium over to Dr. Flynn.
Thank you, Steve, for that introduction. I am very happy to be here and talk about the ABPM statement with people. And let me make sure the Zoom will work here. Great. So we're here to talk about the 2022 AHA ABPM statement, which is published in Hypertension a few months ago, as you can see here. Before we start, I'll give you a brief outline, talk about some indications for ABPM, interpretation of ABPM, and the major question of the day, why did blood pressure load go away? And then future directions. And I will say that this talk is not necessarily going through the statement in any organized fashion, but sort of picking up some topics that I think are more of interest to people. Now, I have no disclosures that are relevant to this talk, and I will not be talking about any off-label medication use or any medication use for that matter. Okay, so if you're on the webinar, you probably don't even need me to go over this slide, but as we all know, there are many benefits of ambulatory blood pressure monitoring compared to other forms of measuring blood pressure, beginning with the fact that it overcomes some of the issues that we see with office blood pressure measurement, including observer bias and terminal digit preference. And then probably most importantly, it allows us to look at different blood pressure patterns, including white coat, masked, and nocturnal hypertension. It may help us to detect secondary causes of hypertension. And then, at least in pediatrics, there are data that show that ABPM can enable a more cost-effective diagnostic workup of the patient with hypertension. And ABPM has been around in pediatrics, at least, since the early 2000s, actually even late 1990s. This slide, which comes from the deck from the fourth report, which was the prior pediatric hypertension guideline, talks about ambulatory blood pressure monitoring as being useful in those conditions that are listed there, and that it provides additional information in underlying conditions like kidney disease and diabetes. It doesn't necessarily endorse the use of ABPM. And then, of course, states that ABPM should be performed by people who know what they're doing. Now, fast forward to the 2017 American Academy of Pediatrics guideline, where now, because there has been so much additional data published on ABPM since the fourth report, it is now recommended and endorsed for use basically in three circumstances. First, to confirm that the patient actually has true hypertension and not white coat hypertension. Then to evaluate patients with high risk medical conditions like coarctation of the aorta, diabetes, and kidney disease. And then thirdly, to assess how well you're doing in treating the patient with actually a specific blood pressure goal on ABPM for patients with chronic kidney disease, and then repeating ABPM in any patient who's treated to make sure that they're at your target blood pressure. And in the statement itself is this table, which gives you many more conditions for which ABPM would be indicated. You can pull it out of the document yourself, but essentially all of the things that I've already mentioned, going from clinic hypertension through aortic coarctation to even research. And we, of course, utilize ABPM in a lot of our cardiovascular research in adolescents. Now, again, all of you probably know this, but when we look at ambulatory blood pressure monitoring studies, what happens? So the device, whatever flavor of device you're using, records the blood pressure, and then the patient returns the device, and someone on your staff will download the reading for analysis. And then that analysis process involves a number of steps. We divide the monitoring period into wake and sleep periods. We do that because there are different normal values for wake and sleep, basically given the expected circadian variation of blood pressure in people. And then each reading essentially is compared to a threshold value and then categorized as normal or abnormal. And in adult, the values are only two, 130/80 for wake blood pressure and 110/65 for sleep. I guess also 125/75 for 24-hour, if that's what you're looking at. Now, in pediatrics, of course, because children grow and their blood pressure changes as they grow, we have different normative data that are used to categorize the readings as either normal or high. And we actually use a 95th percentile value from a database generated a few years ago in Central European children. And then based on that categorization of the blood pressure reading as normal or high, you then sort of decide on the whole study as showing hypertension or not, and then categorize the patient's blood pressure phenotype based upon their office and their ambulatory blood pressure. And you can see here that goes all the way from normal office, normal ambulatory blood pressure means the patient is normotensive, all the way through the other patterns that you see listed there, including ambulatory, white coat, and masked hypertension. Now, just going back a minute to that little tricky question of the normative data for pediatric ABPM. This is based on a study of 1,100 Central European children, most were from Germany, that was conducted in the 1990s. They just recruited about 1,000 or 1,200 kids and did ABPM on them using an oscillometric device. The first analysis of this was published by Marianne Sorgel in 1997 and then updated in 2002 by Elke Vuhl and her colleagues in Heidelberg. And the reason why I bring this up is because these are the normative values that we have been sort of endorsing through all the different iterations of the pediatric ABPM statement going back to 2008. And there are tables, just like if you're familiar with the pediatric clinical practice guideline, there are tables of normal clinic blood pressure or resting blood pressure values. We've got tables of mean systolic and diastolic blood pressure. And this is an example, healthy girls by height. And so there are normal for 24-hour, daytime, and nighttime blood pressure according to different height values. And that is what's used to categorize the readings. Now, there are some problems with these data, but right now, this is the best data that are available. I think relevant to what we're talking about today, the major issue is that, especially for taller boys, the 95th percentile is actually well higher than the values currently used in adults to interpret ABPM. And this has always been sort of a nagging problem that hopefully we have solved by publishing the 2022 statement. Now, the 2022 statement is not the first set of guidance for interpreting pediatric ABPM. The first sort of people to take a stab at this were, I think it was Ron Portman and Empar Lurbe and John Soroff and Steve Daniels and Empar Lurbe, right, who sort of got together and said, well, we need to figure out how to use this device clinically, and came up with this kind of classification scheme, as you see on the table here. And they had a little bit different approach than what I've talked about so far in terms of the categories. They had not just normal and white coat hypertension, they had different stages of the severity of hypertension. And again, they utilized the clinic blood pressure here, then the mean ambulatory blood pressure. And then they introduced the concept of load as a way to also help categorize ABPM studies. I think this is based upon some early work done by Bill White in adults in the late 1990s, who thought that load was a way to help determine how severe a person's blood pressure elevation was. So they incorporated load into their proposal. And so when we got together to write the first AHA statement in 2008, we included load. And then we came up with a classification scheme, which is very similar to what Empar and colleagues sort of proposed, although now calling out masked hypertension. And then this category of pre-hypertension or ambulatory pre-hypertension, which was basically a high clinic blood pressure, a normal ambulatory blood pressure, but a high load. And, you know, I went back and looked at the first draft of our paper in 2008. It actually wasn't there, but it was suggested that we add it by one of the reviewers, and then we did. And then in 2014, we updated the interpretation again, carrying forward this concept of pre-hypertension being an elevated office blood pressure, but an elevated load with a normal mean blood pressure. And then the other categories that you see here, including ambulatory and masked hypertension, and even severe ambulatory hypertension, which is somebody with a really high load. Now, what we just published a few weeks ago is really a lot different. So what you see is just using the office blood pressure here, and then the ambulatory blood pressure here. And notice now we're just looking at the mean value alone, whether the patient's value compared to the cut point, and no longer incorporating load. And we have sort of modeled the categorization system on the 2017 AAP guideline in terms of dividing out the categorization at the age of 13, when we start to incorporate the adult cut points into pediatric blood pressure interpretation. But wait a minute, couple questions come up. What happened to blood pressure load? And then what happened to ambulatory prehypertension? Well, the second question is easy to answer. None of us ever liked it. It left out a lot of patients, and we were happy to find a way to get rid of it. But what happened to load is a little bit more interesting story. And so what is load? I've sort of alluded to it. It's the percentage of readings that exceeds the threshold for that patient. It can be calculated for the whole study, the wake portion or the sleep portion. And as I've already mentioned, it was felt that you could utilize this to assess the severity of hypertension. And so that's why it was incorporated into that very first categorization scheme proposed by Empire, John, and Steve. And you can see, for example, here's a tracing from a patient I took care of a long time ago that had very high loads throughout all of the monitoring period. In fact, this is an example of where load is not even that useful because it's so high all the time. And this patient had high mean blood pressure all the time. Didn't really matter. We had to get her blood pressure down. Now, there's some other problems with blood pressure load. It's not used in other classification schemes. The agreement with mean blood pressure is unclear, and I'll talk about what I mean about that in a minute. It leaves a lot of patients on the sidelines as being unclassified, and this was always a problem. And then, most importantly, including it actually doesn't do anything in terms of categorizing your patient risk for surrogate markers of cardiovascular disease. So let's talk about all of these different things. And I want to mention that what I'm about to talk about, has been reviewed in more detail in this paper by Mark Msnefis as the first author, which appeared about 6 or 8 weeks before the AHA statement was published. So let's start with the adult interpretation criteria. So like I've already said, basically, if you look at the adult cut points and what you would use to determine if a patient had ambulatory or normal blood pressure, it's just straightforward numbers. In fact, what's very interesting is that the numbers are the same as the office blood pressures. And those of you who are from the adult world and familiar with the adult guideline know about how this was arrived at. But basically, just single value cut points and no load included. And then if we look at the European Society of Hypertension Pediatric Blood Pressure Guideline, they also don't use load. They just say, compare the mean blood pressure for the wake or sleep period to the 95th percentile from Elka's tables of Marianne's data, and that's what you used. And then they introduced an important concept, which is actually something that many of us had already been doing, that if the patient's 95th percentile actually exceeded the adult thresholds, then you should top off at the adult cut point. And so what's listed on the slide here are the cut points for ABPM or ambulatory blood pressure according to the European adult guidelines. And so if you were a teenager in Europe and you had ABPM, then and your 95th percentile was higher than, let's say, 135/85 for the wake period, for example, it would just top, you would be abnormal starting at 135/85. And a lot of us were already doing that because of this problem in the original German database. Now, the other question that comes up is whether the use of a static cut point like that makes things easier to interpret the ABPM studies compared to previously. And although this paper from Jason Thomas talks about MAP, what they actually, I want you to look at the bottom, and they actually also looked at using adult criteria for categorizing hypertension in children when the blood pressure was, the 95th percentile was higher, and they found that that was probably what you should be doing, at least in tall males. And then what about this idea about agreement between load and mean blood pressure? So basically, the concept is, you know, if the patient's really hypertensive, they ought to have an elevated mean blood pressure and probably an elevated load, right? Doesn't that make sense? And so a group at Great Ormond Street decided to look at that, and they did this a long time ago, actually. And so they looked at their experience with ABPM over a long period of time, as you can see there, and they calculated the agreement between if you made the diagnosis based only on load, or if you made the diagnosis based on mean blood pressure greater than 95th percentile. And they chose a load of 30%, which is a little bit higher than the 25% we had been recommending, but you would think if it was 30% of them were high, patient ought to have hypertension, right? Well, no. Turns out that the agreement was not that great, only 0.56 for wake blood pressure, a little bit better for sleep. And to get good agreement, you actually had to go up to a very high value of load. And so that's shown here. So this is their table where they look at the kappa statistic for the different parts of the ABPM study, day systolic all the way through night diastolic. And so starting with the 30 percentile load, you can see that the kappa is only about 0.56, 0.57 for daytime. It's a little bit better, about 0.7 for nighttime, but it really only gets to be probably clinically useful, about kappa of 0.9, when you get up to a load of 50%. But a load of 50%, you would already be categorized as having severe ambulatory hypertension, according to Lurbe et al., and then our first ABPM statement. So obviously, there's not the best sort of agreement here. And then there are all these patients that end up being unclassified. So this is a paper that came out of Italy from Urbina. I apologize, I misspelled your last name if you're on the webinar. And they looked at 500 children who were seen for evaluation of high blood pressure in their office. And they, what was their experience? And they looked at their experience and they found that a pretty good chunk of their patients were what they called unclassified, according to the 2014 statement, which was in effect at the time. And there were sort of two patterns. One was a normal office blood pressure, a normal ambulatory blood pressure, but a high load. And then you might even think that that is, sort of masked hypertension in a way. And then the second pattern was sort of elevated normal, elevated blood pressure above the 90th, but below the 95th, and then with a low load. And what they showed was that, there were these 14% of patients that were uncategorized. And we all knew this was going to be a problem even back in 2014 when we wrote the paper, and we all ended up probably fielding, a couple of questions every 6 months from people saying, well, what are we supposed to do with these patients? It was never very clear. And then the real issue is, well, if load is really a valid criterion, then it ought to be useful. It ought to help you figure out which patient is actually at risk of a bad outcome. And so just in the last year, we actually have data to answer that particular question with. One from the chronic kidney disease in children study, and then another paper from the Ship Ahoy study. So for those of you who are not pediatric nephrologists, what is the chronic kidney disease in children study, or CKID? This is an observational cohort study that's been funded since 2003 that has enrolled about 1,000 children from 50 centers over the North America, with the focus on identifying risk factors for CKD progression, risk factors for cardiovascular disease, effects of CKD on cognition, effects of CKD on growth. And so one of the things that we do in CKID is that every other year, every patient gets ambulatory blood pressure monitoring. And they're all read by Dr. Samuels, who's one of the panelists who runs the ABPM Center down in Houston. So last year or the year before, we decided to look at our experience with ABPM in CKID to see, well, did load really help us figure out which child was more likely to have a bad clinical outcome? And so we looked at two outcomes. One was increased blood pressure load and development of left ventricular hypertrophy, and the other was increased blood pressure load and the need for dialysis or transplant, which is a pretty hard outcome. In other words, progression of CKD. And so the graphical abstract is pretty, but let's talk about what was actually done. So, well, I said all this already, I apologize. But one thing about CKID that's interesting is that children with normal mean blood pressure but high load are actually considered hypertensive. And so this is the other thing that we need to figure out whether we're doing the right thing. Okay, so in this, sorry, those slides were a little out of order, I apologize. So in this particular study, we looked at 500 participants in CKID. They all had ABPM, echocardiograms, and estimated GFR data. They were around 13 years of age. As is typical for for pediatric CKD, they mostly had non-glomerular forms of CKD. They have moderate CKD with a median GFR of 50. And so for this study, we divided them into 3 groups: those who are normal blood pressure, those who had isolated increased load only, and those with ambulatory hypertension, as based on their baseline ABPM. And then we looked at LVH and then development of end-stage kidney disease. And so what we saw was that at baseline, those who had hypertension on ambulatory monitoring had a significantly higher prevalence of LVH, 17% versus only 7%. But when you looked at just the kids with isolated high loads, the difference was not significant. It was really similar prevalence of LVH. And then when we looked at, well, what happens to these kids after you follow them along in the cohort? So 11% of them continue to have LVH 2 years after their baseline ABPM study. And then 125 of the 533 developed end-stage kidney disease after about 3.5 years of follow-up. And guess what? High load did not predict either LVH or end-stage kidney disease, but ambulatory hypertension did. And so here are the, get this right, the odds ratios of each outcome depending upon which group you're in. So to the far left, you have the 3 groups: normal blood pressure, isolated blood pressure load, and ambulatory hypertension. And then we have LVH here, sort of to the middle left, and then end-stage kidney disease to the right. And what you see is that isolated blood pressure load, after you did all of the adjusting for different covariates, the odds ratio for LVH was not significant in those with elevated loads, but it certainly was in those with ambulatory hypertension. And the odds ratio for development of end-stage kidney disease was also not significant for those with isolated blood pressure load, whereas it not quite as significant for those with ambulatory hypertension. So basically showing that isolated load in children with chronic kidney disease was actually not helpful in discriminating those children who were at risk of developing one of these problematic outcomes. Now, what about the Ship Ahoy study? So Ship Ahoy study, which is study of high blood pressure in pediatrics, adult hypertension onset in youth. Thank you, Julie Engelfinger, for that acronym. So why did we do it? Well, it's because when you look at pediatric hypertension in general, we don't have a very robust definition of what's considered hypertensive. We look at the distribution of blood pressures in the population, as you can see here, a nice bell curve, and then we decide that, oh, the 95th percentile seems high. So we're going to say that blood pressure values above the 95th percentile should be considered hypertensive. And that's been the definition of childhood hypertension since 1977, when the first pediatric guideline was published. However, there's actually data available, published over the last probably 20 years, that show that blood pressure related target organ effects or target organ injury, whatever terminology you want to use, actually can be seen in children whose blood pressure is normal and not above the 95th percentile. And that I reviewed that data earlier this year in Circulation Research. So Ship Ahoy study is set up to figure out, well, what level of blood pressure do we really need to worry about? And so what we did was, our intention was to recruit 500 adolescents with blood pressures from totally normal, below the 75th percentile, up to the stage 1 hypertension. And you can see here what we ended up recruiting. I got the numbers wrong, I think, because we didn't recruit 500, we recruited 400. Anyway, they all had echocardiography, assessment of vascular stiffness, assessment of cognitive function and urine albumin, and then they had ambulatory blood pressure monitoring, and there was also a basic science arm. This was a American Heart Association funded strategically focused hypertension research network project. That's a mouthful. Okay, so we did ambulatory monitoring using an oscillometric device. We did it for 26 hours. We used participant diary. We did all the calculations I've already talked about. And then, we've been looking at the data in different ways since the study was completed. And in this particular paper published 1 year ago, we wanted to look at what is the level of ambulatory blood pressure that best predicts left ventricular hypertrophy. And then as a corollary to that, or as a sub-aim, does load improve the ability to predict those children who might be at risk of developing LVH? And so we looked at various criteria for diagnosing, for categorizing the results of ABPM and how they predicted LVH. And so there were 327 participants with complete data in this analysis. We developed a list of various potential cut points and then calculated sensitivity and specificity to determine which one would have the best balance of sensitivity and specificity. You can see what the cohort looked like. They had a high median BMI percentile, 92nd percent. About 21% of them had left ventricular hypertrophy using the pediatric cut point of 38.6 gram per meter to the 2.7. Then we looked at the pediatric cut points and we looked at the adult cut point. We actually found that the adult cut points were a lot more useful. So they, if you look at the outcomes here, the adult cut point, or the adult ABPM cut point, right, identified more patients with awake hypertension than the 95th percentile, as you can see here. And that's probably related to those tall boys in the cohort. And the same thing was seen for sleep blood pressure, where more were diagnosed with sleep hypertension using the adult cut points and using the 95th percentile. And parenthetically, I'm seeing this as I'm applying the new ABPM guidelines in my practice over the last few months. And then when we looked at the balance of sensitivity and specificity of the different cut points for LVH, what we saw was that the adult AHA ACC cut point of 130 millimeters of mercury had sort of the best balance of sensitivity and specificity for detecting LVH. And then when we looked at, and so both mean, now when we looked at load, sure, load was significantly associated with LVH in the univariate analysis, but when you looked at multivariable analysis, only mean blood pressure was associated with left ventricular hypertrophy. And adding blood pressure load to mean blood pressure did not improve the area under the curve and the ROC analysis, and so did not improve the ability to predict which patients had LVH. And so here we are again. with the revised criteria, no load, just elevated, is the blood pressure above or below the 95th percentile, starting at the age of 13. And actually, I know for a fact, and we didn't address this in the guideline or in the statement rather, but many people are just topping it out, that if the 95th percentile, even for a child less than 12, is higher than 130/80, for example, they top out at 130/80. I know we're doing that, and maybe there'll be some questions about that later. But anyway, because of the data from the CKID study, because of the data from Ship Ahoy, we felt that there was no reason to continue incorporating load in the interpretation guideline. So to sort of wrap up a little bit, I think I have shown you, and you probably could say this yourselves already, that ambulatory blood pressure monitoring is a valuable tool in assessing and monitoring blood pressure in children and adolescents. And we've talked all about the different indications. Publication of some recent data have allowed us to simplify the criteria that are used to analyze them and sort of bring the American or AHA sort of recommended approach into alignment with other approaches for interpreting ABPM. We're going to now sit back and wait and let people show us what this actually means in clinical practice. Does it mean we're going to have more ambulatory hypertension? Does it mean that we're going to have more sleep hypertension? Certainly makes the process of interpreting the studies a bit faster. I think I'm down to like 3 minutes per study now because I don't have to look at load. But we need to see, what is this going to mean? I think we did the right thing. I think the changes we made were evidence-based. And of course, like with many other things, time will tell whether or not the new scheme really holds up and will be useful in sort of both clinical practice and then research and so forth. Acknowledge all of my partners in crime on the statement, and then my the PIs of the chronic kidney disease in children study and my co-PIs in Ship Ahoy, and our funding, as you can see, NIDDK for CKID and American Heart for Ship Ahoy. And I thank you for your attention, and I think we have time for questions, and then my email address is there as well if you have other questions after the webinar.
All right, thank you very much, Dr. Flynn. We do have a number of questions for the panel, for Dr. Flynn, and also the panel to discuss, and I'll kind of pose them one by one from the attendees. The first question is about how the reimbursement, the cost of ABPM affects how often this is done, and how can you address that? Is there in adults it's not well reimbursed, so how do you address that in kids?
I mean, I think that gets back to the statement that, both in the AAP statement about hypertension in children and adolescents, as well as now the American Heart Association specifically looking at ABPMs, mentions that ABPMs should be performed by specialists who read ABPMs and know what they're looking for, which makes it, there will be fewer programs that have a larger number of ABPMs rather than each individual pediatrician out there buying their own monitor. I don't know that that's a cost-effective way to run an ABPM program, particularly when a lot of us are not getting a great reimbursement. That's different depending on where you live. I suspect we have people from all around the world on this webinar. Depending on where you live, reimbursement may be different, but the machines are still, in my mind, excessively expensive considering where technology has gone.
Yeah, I have not too much to add to that. I mean, we get paid most of the time. We don't get the physician interpretation fee is not that great. But the facility fee is, and that's how your, institutions can recoup the cost of the equipment.
All right, we have a second question about the morning surge and pulse pressure and how that relates to cardiovascular risk in children. Do you use that in your assessment and treatment every day?
So I'd like to take that one. There are some data from my institution looking at morning surge in kids with sleep apnea, but there's extremely limited data on the utility of the morning surge in pediatrics as it compares to in adult ABPM. So I would state that most of us are not looking at morning surge in pediatrics. And then in terms of pulse pressure is a rough estimate of arterial stiffness, which is of interest. But when you're using a oscillometric device to measure blood pressure, and you'll see it in the German normative data, diastolic blood pressure is flat across age and across height. So I don't think I have a great deal of confidence in measuring pulse pressure with ambulatory blood pressure.
Right, and we see that with age in mainly older adults. So I guess in kids, it's not such a big issue. Is that what you're kind of alluding to?
I'm just saying that measurement of diastolic blood pressure with oscillometric devices may not be entirely accurate. And so I'm not convinced that you can calculate pulse pressure accurately. And there are other better ways to look at arterial stiffness than pulse pressure, which is a very rough estimate of arterial stiffness.
Okay.
We know that for office-based blood pressures with auscultatory devices, and frankly, with some of the oscillometric devices, as kids get older and taller, their normative blood pressures go up. We see that with these oscillometric ABPM devices on the systolic side. The diastolic seems to be relatively flat. The normative data shows a diastolic 95th percentile of around 80 or 81 for all kids, regardless of age and size. And I agree with Dr. Urbina, that just doesn't make sense.
So then you're saying, okay, everyone who's an adolescent has a wide pulse pressure and increased stiffness, and that doesn't make sense.
Right. But the older you get, the smaller your pulse pressure is, according to normative data.
Okay, another big question that came across was whether there's enough data on different populations, specifically different races, ethnicities, to really apply that to different populations. And is there rationale for treating to different targets in those different populations?
Yeah,
Well,
I'll take that.
Okay.
So I would throw the question back at the person who asked it and ask them a question as to whether there's a difference in the biology based upon a social construct. And so from that perspective, the answer is obviously no, we would use the same normative data.
But I think an additional answer to that, Joseph, would be the normative data we have does not include a multiracial population like we have here in the United States. And several of us have tried to get funding to do that before we decided to have adult cut points with kids age 13 and up. And now that we have static cut points for 13 and up, I think it's going to be even harder to convince people to get normative data because it's only going to be useful for kids under the age of 12.
Yeah, and and then there are a couple of studies like from Greg Harshfield, for example, that showed Black adolescents have higher ambulatory blood pressure, which probably reflects structural racism and social determinants of health. So, I guess it would be great to have, a multi-ethnic normative database, but, I throw the question back at the questioner.
And I also say that I don't have any a priori hypothesis that elevated blood pressure in one of these subgroups, whether it's by race or ethnicity or by chronic kidney disease versus primary hypertension, to me, the biology of causing that bad outcome of cardiac or kidney damage is going to be the same. So maybe we're observing higher blood pressures in certain groups, but the level of blood pressure that they're at is going to affect the heart and the kidney in the same way.
Steve, I think you're muted.
Hi. So I had a related question. This is Steve Crowley. I was curious if APOL1 variants had been linked to complications of hypertension that is detected by ABP in children.
I'm not aware of any data.
Positive or negative. I don't know that that's been studied.
Got me.
Joseph, do we have APOL1 data in the CKID population? Because you wouldn't want to only study it in kids with chronic kidney disease, but we have that data for CKID. We could look, but again, you'd want to look at a fresh cohort, not just kids with chronic kidney disease.
Yeah.
We've got stored blood for Ship Ahoy, but just no money.
And that's a great question because it's definitely associated with worsening hypertension and more difficult hypertension in adults. So it'd be interesting to see that in kids. We have several questions in the chat that are asking about nocturnal blood pressure specifically compared to using the 24-hour average and how that applies to cardiovascular risk.
So I can try to take that. So I think, one of the things, and I think it sort of goes along with one of the questions I think somebody else was also asking about which ones to use. And I think the new update, is clear that we are not just looking at 24-hour, but we're looking at, wake and night, because they all independently can impact cardiovascular disease risk. And one of the benefits of 24-hour ambulatory blood pressure monitoring over home blood pressure monitoring is you're able to identify nocturnal hypertension. And we do know that, or we have some evidence to suggest that accelerates chronic kidney disease progression, and again, has increased cardiovascular disease risk, particularly in some really vulnerable populations. So again, kids with transplant and kids with chronic kidney disease. And so, so we do know that it is associated with increased cardiovascular disease risk. I feel like I'm missing the second part of the question that you were posing. I just lost it. I'm sorry.
I think that's primarily it. We focus on it a lot in adults because it ties so tightly, maybe more tightly than daytime blood pressure for cardiovascular events.
Right.
So I guess how strong is that data in kids? I guess is one of the questions.
We just published in Hypertension a different article, but we looked at this in the CKID population, and there weren't enough kids. I mean, one of the things about adult studies that look at this is they get literally thousands and thousands of adults. But we did look at kids who had sustained hypertension, which is both day and night, versus kids who only were hypertensive at night versus kids who were not hypertensive at all. And it did look like the kids who were hypertensive only at night were at an intermediate risk. They weren't as bad off in terms of CKD progression as the kids who had sustained hypertension, but they weren't, as well off as the kids who had normal blood pressure through their ABPMs. But I don't think that those differences were significant because, again, we didn't have thousands of patients. We had, a couple hundred in each arm.
And I think that MPAR published a paper on nocturnal hypertension and progression of microalbuminuria in diabetes. So I think that it may be an issue in people, in adolescents with diabetes.
just because it was asked in the chat, someone also asked about 24-hour MAP and where that comes into the guidelines. And I think that comes in specifically in kids with chronic kidney disease. And that is an offshoot of the ESCAPE trial that was done in Europe that used 24-hour MAP. And they treated everybody with an ACE inhibitor and then had certain kids that were intensively treated versus standard. And the kids who had their blood pressure treated to lower than the 50th percentile MAP over 24 hours had a slower progression of their chronic kidney disease. And that got incorporated into both the 2017 AAP guidelines, as well as I think these most recent AHA guidelines.
Now, one thing that is attractive about MAP is that in oscillometric devices, MAP is measured directly and systolic and diastolic are calculated. However, in clinical practice, it's a little harder to keep the numbers in your head. And so we use systolic and diastolic in interpretation. But I think if you're trying to compare between different devices, MAP might be useful.
And you can certainly program in systolic and diastolic thresholds that you're interested in, and it will give you, but MAP, at least the software that I'm familiar with, you have to look that up separately. Dr. Flynn does it in less than 2 minutes, but it takes me a little longer.
Yeah, it's cumbersome.
Well, for the CKD patients, take me an extra few seconds to look that up.
Well, in the last 2 minutes or so, ask a question that may have no answer, but have the data that you have accumulated given you guidance about which specific classes of medicines work better for things like masked hypertension, white coat hypertension, dipping? Don't know.
So we are in conversations with NIH about getting a randomized clinical trial going. But no, those data have not been collected.
Yeah, I mean, all we can tell you based on sort of the CKID study is that if you have kidney disease as a child, you should be on a RAS blocking agent. But beyond that, and then, just like we say all the time, you should probably be on a medicine that works, all day. And but beyond that, can't say much more.
All right. Well, we'll take this opportunity now then to thank all of our speakers and our panelists for their insights today. Again, like to thank Trudy for organizing all this, Jonathan Schultz for providing the IT so it could happen. Just want to make sure that Trudy doesn't have any other comments to add regarding switch over to Twitter or whatever.
Yes, if anyone has any follow-up questions or we have any additional questions that are known via the Q&A, we will follow up. If anyone wants to follow the journal on Twitter, our handle is, sorry, let me make sure I get it perfectly correct.
Hyper AHA. Yes,
at AHA, Hyper AHA. And our specific webinar series hashtag is hashtag Hype Ed series, which we're pronouncing Hyped series and stands for Hypertension Education Series.
Super. Well, thank you all and hope you have a wonderful evening and a nice week as well. Thanks again. Look forward to another webinar in the not too distant future.